it's not other ways, but it really is about out-of-pocket expenses. In fact, they are almost more than 60% of current healthcare expenditure. So each one of us is financing out-of-pocket healthcare, putting down money. Obviously, the key question, if we had to look at universal healthcare, and this causes at least 7 to 8% of families to go into poverty every year. And we're not even talking about people who can't afford it, so they don't actually even get healthcare. So if you have to solve sort of universal healthcare, we've got to figure out how to optimize out-of-pocket expenses. And this is something I'm very privileged to be working on with my colleagues Bindu Anand and Tejasvi Ravi and Sakshi Halan. And we're really looking at ways that this out-of-pocket can be optimized. And the only way it's going to be optimized in some ways is by really shifting the focus from very high cost hospital care, very acute care, to much more preventive care, to better adherence to medication and to care. So really just getting people out of hospitals are really good, but they're also very expensive. And so really trying to get people out of hospitals and, really look at healthcare as starting much earlier and in different locations other than hospitals. And that's really the theme of our webinar today, meeting people where they are. Healthcare shouldn't be something that you go to a particular location. It should be really something that meets you where you are as a person. And so I'm really excited today to introduce three sets of panelists, three organizations that are really about some innovative models of healthcare. So first off, I want to introduce Dr. Shahid Alam from Noura Health. And thank you to Noura for co-organizing this webinar with us. Shahid is the co-founder and the co-CEO of Noura Health. And prior to Noura, he focused on research and advocacy to improve healthcare for incarcerated populations, prison populations in the US, and developing low-cost technologies. He's an associate faculty at the Harvard Chan School of Public Health. He is a GLG Social Impact Fellow since 2019. He was named a Stanford Mary Biddle Duke Global Health Scholar in 2015, a TED-Med Entrepreneur in 2016. And he has a long list of several other very impressive credentials. He has a BS in Biomedical Engineering and an MS in Public Health from Johns Hopkins University. He's also a doctor. He has an MD from Stanford University. So welcome, Shahid. And a shout out to Shahid's co-founders also on the call, Edith Elliott, who is the co-founder of Noura and has a long history of training in public health. And she before Noura, she worked at Aspen Institute and Population Services. Along with Shahid, we have the very, very impressive, I'm looking at her CV and telling her I'm a little intimidated, Dr. Baljeet Kaur, who's currently the Assistant Director in the Office of Directorate at the Department of Health and Family Welfare in the Government of Punjab. And Dr. Kaur has this amazing resume, but I'm just going to say that she's been in medical practice for many, many, many years, and across contraception, abortion care, advocacy for safe practices for HIV/AIDS, and she initiated the Health and Wellness Centers for Punjab, implementing the Ayushman Bharat program of the government. So welcome, Dr. Kaur, as well. Our second organization is, and we'll hear about Noura, about their program at home, the companion care program, and how it sort of solves for this, meeting people where they are. As we know, in COVID, we spent a lot of time at home. The second panelist I would like to introduce is Swati Rohit. Swati is the founder and CEO of Health Basics. It's a platform that's a mission to transform pediatric healthcare delivery in India. And she served as the COO of SNR Sons Trust for 12 years, and they have a 1,000-bed accredited Sri Ramakrishna Hospital, 17 educational institutions. So she's very well versed in this link between education and healthcare. Again, Swati has a long sort of resume, but I just want to say that she set up, she's also Guinness World Record holder for a maximum number of signups in an 8-hour period under a Gift the Organ initiative. She has a degree in mechanical engineering from the University of Virginia, and she's a hands-on mother to her 15-year-old son, which I think is much of her interest. So we're going to hear from Swati and Health Basics about a very innovative school program around preventive care. And finally, it's my great pleasure to welcome a neighbor, Rubaiyat Khan from Bangladesh. Rubaiyat is a Bangladeshi serial entrepreneur, and he's really passionate about taking health services to the underserved populations. He's currently CEO of Geon, and it's a social enterprise. It runs a network of over 5,000 pharmacies. So talk about where people are, where do they shop, which is pharmacies. And what's interesting is the pharmacies are upgraded to provide care and services. He's also the co-founder and director of Empower Social Enterprises. He's a fellow of the Aspen Institute and Acumen Academy, has a master's in international development from Harvard. I think what was impressive to me is he taught himself to code at the age of 8. I don't know what I was doing at the age of 8. It wasn't coding for sure. He loves watching Black Mirror. So welcome, Rubaiyat. I'm sure there are very interesting lessons from Bangladesh that we can actually use here as well. Okay, so that was an interesting introduction to our panelists. But before we dive in a couple of housekeeping items, the session will be recorded. It's currently in progress. And please drop questions in chat. We will be monitoring the questions. We'll try and finish the bulk of the webinar within the hour, because we know people are really busy. But we wanted to keep the extra 30 minutes because we did want people who have questions to really engage in them. So our panelists will stay on, and we're very happy for those of you who want to stay on for the remaining 30 minutes to actually stay on and have more of a discussion around this. But before we dive into models of healthcare, at least, I don't know about you, but at least for me, sometimes healthcare is very abstract. We talk about models and systems and, financing, and these terms are very abstract. And sometimes we forget, I think, who we are sort of designing this universal healthcare for. So today it is my pleasure actually to welcome a very generous volunteer, Navya, who is actually going to talk about a little bit about her journey with tuberculosis. And I hope that as we are doing this webinar, we keep patients and people like her at the center of what we are actually trying to do and solve for. So I don't know if Navya's on. Hi, Navya. Hi. Well, first of all, thank you for coming. And thank you for being so generous to share your story. And it's really critical that we don't just sit in a vacuum and design, but we actually know what and who we're designing for. So I'm going to ask you questions, but feel free to talk about your healthcare journey. So can you tell us a little bit about yourself and specific? It's hard to identify people just by their disease. You do a lot of other things. It's not just your disease, but like in this context, a little bit about you and TB and just yeah.
Hi, and thanks, Neela. It's actually funny for me to be here and getting to talk to you about my experience with TB, because I was working on lung function research, and I was a PhD student when I got infected with TB. I was working with MTB cultures and performing lung function tests on school children. And oddly, I was caught up off guard when I was diagnosed with TB a year later. I'd been having symptoms on and off, but there was always this feeling that it's really unlikely for me to get infected with TB because I seem to know so much about it. But there I was, and I was a penurious PhD student, as most PhD students are. And I think I was one of those people who belonged to an invisible subgroup of patients. There are many, many reasons why subgroups may be invisible from conversations around access to healthcare. And grad school students are also part of that subgroup, however unlikely. One of my professors noticed my profound weight loss, something that my doctors had not been able to notice, even after several consultations. And she recommended that I go to a hospital and get tested. And luckily, I went to a private healthcare facility, and my TB was caught through an FNAC test. And I started my 3 drug regimen. Um, I had a wonderful and empathetic doctor. Uh, I felt safe talking to him, but he didn't have more than 2 minutes during a particular consultation to spend with me. I'm sure he did intend to warn me about what to expect, but he simply didn't have the time. So what happened was that I'd get sick very frequently, and I lived alone. I didn't want to involve my family in the beginning, so I would have to take myself to the hospital because I would catch whatever was going around. And for the first 2 months of my treatment, I didn't really show an improvement. So I was practically sent back from my workplace. I used to work at the Indian Institute of Public Health. I was a student there and I used to work there. So they sent me back and I came home. I was with my family and I was fortunate enough to be one of those people who had access to family doctors who were deeply invested in me because of our family relations. And that support helped me improve drastically. And within another 2 months, I was back to being physically active, being able to play sports again, and get back to my PhD program just the way I'd planned. So I was fortunate enough to get a lot of support when I needed it. But I would also want this kind of support to be made available to people who may not have been as lucky as me, who are underrepresented in these conversations, and more invisible subgroups,
Yeah, yeah,
who can talk to their healthcare providers, who can ask
yeah.
their questions and get the help they need.
And you've laid out so many aspects of this journey. And thank you for talking about it such an articulate way. That struck me. The fact that you didn't think that you were the audience of this disease, right? So just underestimating, which a lot of us do with a lot of conditions. We underestimate the risk, our vulnerability to things. I'm sure that's happening with COVID right now. You totally underestimate, I'm young, I'm healthy, I'm not going to get it. You talked about sort of the duration of almost a year between the time that you sort of noticed those symptoms and went in to seek care, and because someone noticed it. But it was interesting to me, like you said, your professor noticed it, but the doctors didn't really even notice that. And I think your point is really well taken. The fact that, you live alone, but you do have a support structure, which is a different situation than someone who might live in, say, a joint family and has to deal with maybe a great support structure, but also stigma of living with other people. And, so there are all these challenges. And the thing that really struck me is how much of, as you said, your journey was informal support. Because, as I think you very generously said, you were lucky enough, but, not everyone has that kind of informal support. So, I think that, so let me ask you, you're in recovery now, you said you're back to sports. And so is it a maintenance regime, or do you find it difficult to, now that you think you're cured, that to sort of, be careful or do things what happens now?
Well, this was several years ago, and I think I went back to certain unhealthy habits after that, but it did leave me with a sense of questioning my idea of being completely invincible, and definitely left me with some sort of appreciation for taking care of my health. Usually, it takes these events to jar you back into being alert and responsive to your needs. And I think that's what most of us need, to not be reactive to our circumstances, but prepared for them.
Yeah, no, that is it's so easy to forget, I think, even when you've gone through a serious illness, and thank you for reminding us about it. So thanks a lot, Navya. I'm just going to throw it open to our panelists to reflect a little bit before we get into your specific models and what struck you about Navya's story as examples of sort of broader healthcare. So Shahid, Dr. Kaur.
Sure. Yeah, we'd be happy to kick it off. And thank you again so much, Navya, for sharing that story. I think three things really strike us, which is relevant to our work. One is initially, Navia, when you were mentioning the time of providers, I think that's something that we know is a challenge throughout care in South Asia and India. I think studies have found exactly what you experienced, just about 2 minutes that providers typically spend in consultation, in conversation, in even these critical diagnoses. um, I think the second, of course, is your story around on your support system, um, both traditional and non-traditional, and of course family as being a force binding it all together, and the importance of them and others through that network that in your recovery. Um, and then I think that your answer to the last question that Neela just posed, in terms of how TB and that experience, that critical moment in your life and critical moment in your health, was a turning point in some way. And yes, you said maybe you got back to some some behaviors that were unhealthy afterwards, but it was an important time for you to engage in your health. And that's something that we've also seen through our work, is we can really leverage these times to help improve people's health in the long run, not just their own, but their extended family. So of course we'll go into a little bit more about how maybe that's specifically relevant to our work, but that those are three things that stood out.
Yes,
Dr. Carr,
Dr.
anything?
Kaur. I mean, the 2 minutes that the doctor spent is, it really struck me, and would love for you. You're a busy provider, I think, to give some perspective.
So that is the truth. See, we are so many in number in this area, and the kind of healthcare burden that we are carrying is very heavy. So that's the kind of time that is usually available, and we need to use more intelligent technologies and ways to add on. And that's
Yeah.
where, like, we've chipped in, and I'm very grateful to Shahid for introducing this program. We'll be talking about it later, but I think that gives a big solution to what Navya Mishra has gone through. I wish we had implemented this program many, many years back, and Navya wouldn't have had this problem.
Yes, I would have loved to be able to ask questions. That's what I miss the most as a biologist
That's
and as a patient. So,
No, I mean, I think, and we should keep holding it, right? So if the healthcare system, because of, and you've heard from a doctor, because of the way doctors are burdened, they can only spend a very specific short amount of time, then we should be looking at other ways to do this. Rubai, would love your thoughts on this.
Thank you, Neela, and thank you, Navya, for sharing that so honestly. So I think I'll reflect on a few issues, mostly talking about what an illness like this might mean for less privileged populations, right? Similar to Navya, when you get sick, usually you don't seek treatment from a doctor as your first option. In fact, oftentimes, if you're a poor person in a country like India or Bangladesh, going to a hospital or a formal sector physician is your last option, because it's costly. It sometimes requires a fair bit of travel and logistical maneuvering. God help you if you're a woman. And it's downright scary because you're navigating this really complex, unintuitive maze or labyrinth of a healthcare system. The other point that often gets missed is, for a poor person especially, it can also be quite demeaning to reach out to a formal sector facility. So if you care about your dignity, which almost everybody does, you don't really go as a poor person to a formal sector facility, because the respect and care that you receive is often directly proportional to your caste or socioeconomic class. So in that sense, Navya was lucky that she comes from a more privileged background and was received with empathy and care, which most poor people would not be, right? They would be dictated to do a few things with not a lot of respect and would be done with it. In fact, in Bangladesh, a study came out, a cross-country study came out that showed that the average physician was spending only 43 seconds with a patient. So if it's 43 seconds on average, imagine what the smallest consultation is like, right? And also the final point that I want to make is the informal support that you got from family physicians, Navya. That's also something that you or I or us in this panel are probably lucky to have. But I want to point out that the closest thing poor people have to a family physician is usually a pharmacy or other informal providers that are close to them, right? They don't really have an MBBS or a specialist doctor as their family physician. So that distinction of we tend to look at pharmacies as a dispenser conforming to a Western notion of a pharmacy. But in our countries, a pharmacy or many pharmacies actually are also village doctors or rural medical providers. And they actually serve as the family physicians of the communities that they serve in. And that was another kind of reflection that I wanted to share.
And I loved your point about dignity, because people make choices not because it's the best choice, with the best sort of most advanced healthcare, but they also make choices based on their experience and where they would be treated with dignity. And so I think that's part of the theme of meeting people where they are. They might be more comfortable in a non-medical setting because they're assured of being treated well. There's a lot of trust, and we'll hear a lot more about Gion and the specific model there. Swati, any thoughts from from the sort of pediatric healthcare and what you're trying to do?
Very interesting, Navya, that you brought up the point that you actually did discover this when you were looking at a school population. So very often one of the major problems with TB or any other disease, whether it's pediatric or the other population, tends to be early diagnosis. You were lucky that you had great healthcare and you were able to, get diagnosed early. So a big part of what we do is, and what we spend, especially with health education in schools, and the nodal point of putting an in-school clinic so that there's constant monitoring of the kids, is the question of early diagnosis. And also every month and every week, we take the opportunity to educate the children, not just about diseases that they would come across in their day-to-day lives, but also, what really to look out for as a person, as a functioning human being, right? Are you feeling tired? What is not natural and what is normal and what is not? And to ask these questions constantly, and anything at all, they have a resource that they can reach out to. And that's what we want to provide in the lives of these kids and families.
And I think that's another great point, which is that we don't recognize that the situation is abnormal if everyone around us is that way. And so part of this is not just to recognize specific diseases, but as you said, many of these diseases arise from very innocuous symptoms, right? A cough, a cold, and you might feel that, yeah, this is nothing, a little bit of weight loss, there might be gender stereotypes, things like that about so these almost go unnoticed in some way. And part of health is not just identifying diseases when they occur, but even having a good mental model and training around like what is actually good health, what does it look like, what does it actually mean, and maybe catching them early. So thank you all. I mean, this was Navya, good luck. Thank you so much for sharing your story. I think it's really set off a lot of reflections, and we'll definitely be keeping it at the center as we go through this webinar. So now I'm going to turn it over. Thank you. I'm going to turn it over to each one of you. You talked a little bit about, the model that you are really, you've innovated around healthcare to meet people where they are. So love for you to talk, Chad, Dr. Korobat, Swati, to talk about the models, specifically maybe touching upon, who are you serving? And a little bit more around, how does it actually work, the nuts and bolts of this operation, and why did you actually come up with this idea, a little bit of which you touched upon. So I'll start with Noura and Shahid and Dr. Kaur.
Sure. Thank you, Neela. So essentially, the big picture problem that we're trying to solve is to reduce the tremendous amount of preventable morbidity and mortality that exists, especially in India. And essentially, how we do this is to help health systems do a better job of training and engaging the family member of the patient within the process of healthcare delivery. So our hope would be that a patient like Navia is through the health system getting the support that they need at the time of diagnosis or treatment, um, to be able to understand what are the health behaviors that they need to perform, and being able to be supported throughout that journey longitudinally as well. So how we do this is that we partner primarily, we work with the public sector at the moment. So we partner with government health systems. In India, it's states, and actually we just began work in Bangladesh as well. And we partner with them and essentially enter into an MOU and a cost sharing agreement where Nora Health provides certain things, and the government is also an equal partner in implementing and delivering this program. What we provide as a technical partner is developing engaging content that's focused on health behavior change in local languages with kind of the regional context that's important for people to actually be able to recognize what some of these topics mean for them. We train healthcare providers on the ground, staff who are there day to day interacting with patients who might have those 2 minutes, but how can they use those 2 minutes effectively, and how can we organize care so that we can compound those 2 minutes and essentially be able to deliver something more effective to families. So training providers not just to be technicians but educators is something that we believe in. And the third is to bring in technology. We do believe that a lot of this needs to happen in person. Healthcare is personal, and that's why a lot of the training and engagement that we try to bring about is changes that happens between people as they're interacting. But of course, in order for it to be scalable and have the greatest impact, we need to incorporate technology. And the two ways that we do this, one is once someone is being trained or after someone's trained by a provider within a facility, they get followed up through a mobile messaging platform where they get messages, media, and they can also ask questions that are relevant for their patient. Through this platform, we currently don't provide prescriptions and specific clinical diagnosis and treatment, but 95% of the questions that we get are very basic. They can actually be answered through an FAQ type, that we've built. So that's the majority of that, what that interaction looks like. We also have a platform that's provider facing. And helps them be able to run this initiative within their health system effectively. So through this initiative, we've been able to see, as relevant for this conversation, things like reductions in complications for patients, and also readmissions. So people are not going back to the hospital as frequently and being readmitted for conditions that could have been prevented by their own actions at home. And we've seen this across multiple patient populations like newborn and cardiac care. And we've also seen similarly that outpatient care actually increases a bit. So we see this shift from tertiary care to primary care through engaging people better in their own health. In terms of answering your question, Neela, about like who is this applicable for, we feel anyone everywhere. Really any type of patient, no matter where they're getting care or the type of condition they have, needs some sort of information support, and their families are involved. So we're there so we feel that it's applicable for essentially everyone. One challenge, and really glad that we have Rabayat and Swati to share your innovations, because one of the challenges that we have is that currently we do this intervention is coming through the health system. So while we are building capacity outside of it, we're empowering people in their homes, especially. It's being delivered through the health system. Of course, that has a lot of pros as well, but I won't get into that now with respect to time.
And we talk about that
Yeah.
a little bit more. Yeah. Dr. Kaur, anything to add on that? I had a few sort of thoughts as Shahid was talking.
Yeah, I think Shahid has given a brief on the entire program. As far as the implementation is concerned, we partnered with Nura Health and we found wonderful results. What Navya faced is something which my clients now in my public health setup are not facing. And I'm
Mm,
so proud that wherever the sessions are happening, we are making the change. And it's the things that were normally being supposedly to be delivered by the healthcare system. Me as a doctor, when I was doing my clinical work, and my nurses who were looking after my patients in the wards are now able to do it in a very different manner. And they're able to do it more effectively. And the resource that was considered as a non productive resource and a nuisance resource of having relatives and caregivers inside the hospital setups, they have been converted into our asset. So that's
mm.
where we have gained as far as this program is concerned. And I can go on and on for hours and hours and days explaining you that how much of impact we have seen in our systems, right from keeping the wards clean, taking care of the patients, taking care of the beds, taking care of the patients while they're in the ward, while back home, and getting themselves educated, spreading the education further. My own HR being so motivated, so active, so happy that they're able to share their knowledge and share the information that they have. And they have a sense of, increased self-esteem because they're
Mm-hmm.
stand before a couple of set of people every day and take up some questions and answer their doubts, and it gives you so much of joy and happiness if a lot of navyas felt satisfied and assured while going back home.
That's great. So, just to round up what you were saying, this idea that the family is actually, it's not a nuisance, it's an asset in healthcare. That it's not against, it's not family versus doctors, it's families as part of healthcare, really struck me. And the other thing that actually struck me, which is such a simple insight, is that we need to be trained to do this, right? We need to be trained about caregiving, because we all think we can do it. What is there if there's a patient? But to do it systematically, to do it when there are obstacles, it is like, it's not just about us learning math and English and sciences in school. We need to be trained about this. I think that's the theme of a lot of this, that people don't just pick up healthcare and become experts, but it is possible. And what struck me is, it is possible to have change, right? It is possible to reduce, complications, to reduce readmissions, to shift to primary care. If we train the family, ordinary folks who don't have, medical degrees, to look after the patient better. So thank you for sharing your experiences, and that leads to a good segue to Swati to talk about, a big forum where training, when we tend to think of education and training, we think of schools. So would love to hear your thoughts, Swati, on how the Health Basics model it works.
Sure. Thank you, Neela. I think I'm going to start with the why we did all of this and what really, motivated us. So before I started Health Basics at our charitable hospital in Coimbatore, Tamil Nadu, it mainly served households from the missing middle, which is an income group of like the 6,000 to 40,000 a month rupees. These are also the income groups with our households with the highest out-of-pocket, expenditure on healthcare. We worked on a propensity to pay model where people were given subsidies according to their ability to pay. During my time at the hospital, it was very common practice for a lot of private hospitals and organizations like the Rotary to do in-school camps, general health as well as dental and eye. So what typically happens at these camps is that the checkup is done and the students go home with a sheet with all the health data. We've been doing this for over 20 years at the hospital. But one thing really struck me, when we realized, and we convinced ourselves we were doing a great job of diagnosis, early detection, and all of that. And we actually looked at the percentages of the children or family members who were coming back in, who turned up for the recommended treatment or a follow-up. And it was abysmally low. It was actually something like 5%, which shocked all of us. And this health statistics for kids in India is also quite alarming. Of late, you see, in the 20 percentile, whether it's myopia, obesity, 1 in 5 is pre-diabetic, even dental issues, like, imagine 1 in 3 kids has a cavity. I know it's quite alarming. This got us, looking at the whole situation. And constantly when people talk about universal healthcare, I think I was listening to one of your early webinars, and I think Mr. Tarun Khanna said it, that the focus is not just on hospitalization and medication, but also on prevention. So that's what brought us to the drawing board. And, we asked ourselves the question of, what should an effective school program really look like? How are we going to fix this? And to give a brief introduction to our model, we did a study to find out the main pain points of the children and families, and why this indifference when it came to kids' health, right? So parents have a lot of content coming at them, whether it's social media or WhatsApp, whatever it is, right? But nothing sticks. And whenever it comes to their children, it's always a reactive mindset, right? If they fall sick or when they fall sick, let's look at it. So we realized that unless they had very specific things about their child saying, your child has this, they weren't really going to act on it. So we really focused on early diagnosis. And that's where our in-school clinic came up. We go into a school and put up a fully equipped basic clinic manned by a qualified nurse and a doctor who's available online to consult at any time. We also do a one-time 128-point assessment that covers for every single child anthropometry, vision, dental, hearing, and mental health. So the second issue that came up was, constantly was inconvenient family access. Most clinics or hospitals have really outdated tech. So you typically see a parent or go in, or a family go in and wait a whole day, take an appointment, see the doctors, do all the tests. And usually it means like the loss of 1 whole day's pay. And it's usually huge in this income group, right? So what we did to fix that was we put up a 24-hour cloud clinic where parents can call and check in with one of our doctors. And if required, then they set up a physical appointment for the, parent. Through the system itself, the appointment is done, through our appointment booking system on the app, as well as there's a concierge. And the third main issue that we came up with was a lack of trust. That was a huge problem that we saw with parents, whether it's the children or anybody. And so just to address that, we put in a 24-hour concierge to answer any of their queries, and just to triage and point them in the right direction, have someone to say, what, you have a problem, we're here for you, how can we help you? And I think if you've ever had to go into a hospital in an emergency situation or call to figure out a particular thing, I think it's a truly scary, harrowing experience. You put on hold, you really don't know who you're talking to. The operator usually comes on, they're not very well trained, and it's quite scary for the average person to go through that whole experience. So we also wanted to incentivize these people to actually take a call to action on all the problems that they found with the through these assessments or for themselves. We gave them a family card to local clinics and hospitals, which we found to be reputed, so that they could actually use this to avail a couple of discounts. So that's really what we started with, an in-school clinic, a cloud clinic to answer the parents' questions and triage the parents or the family members or children. And the third is an appointment booking system that guaranteed them an appointment when and if they needed one. So the last mile connectivity as well. So the whole continuum of care, basically.
Yeah, and I think that, and just this notion of trust, right? And so two things, I think one, and very related to what Navya spoke about, we don't think that, if you're young and you're healthy, you look okay, and especially if you're a kid, you don't actually think that there could be anything long-term wrong. Even if it's if some early issues, you think, well, that's going to happen. So I think you're totally right that unless there is a trigger to act in some ways, it's not going to actually happen. But many of these are sort of long-term issues that may flare up later on. So, school is a great place to do that. But I love this idea of trust. I think something Rubai also talked about, right? And again, the reason that meeting people where they are is not just convenience. So I think that we tend to think that, oh, it's convenience, but it's also the experience. It's the dignity, it's the trust. It's the fact that, as you said, it's a harrowing experience often to be at a hospital. And actually, and I think Dr. Kaur said this, actually part of that comes from, because we're putting too much on hospitals and doctors. And so if we actually were to help them with some of the stuff they don't need to do, then actually that experience might get better. Maybe instead of 2 minutes, it becomes better, but also just, the patience of the doctors, the ability to answer questions that comes because they're freed from a lot of the other work that they need to do. And the final thing that really struck me, and that's a good sort of segue to Rubaiyat's, to Jian, is this interplay between technology and human beings. So in both the Noura model as well as your model, I see this idea of, technology can do many things powerfully, but it can't substitute for human touch and human resources and humans. So the challenge is figuring out, and the key to unlocking this puzzle is to figure out what technology can do well and what that human being can do well, and how do you actually marry the two. So I'm going to come back to you in terms of the challenges and scaling up, but I'll turn it over to Rubai to talk a little bit about Jian.
Thank you, Neela. And it was lovely hearing from Shahid and Swati about their models, because there's so much about what they were saying that resonates with what we have encountered in this space. So if I had to summarize in one sentence, Jian essentially upgrades neighborhood pharmacies to be quality primary healthcare providers, so that underserved populations could get better quality healthcare where they are. But because I have 2 minutes, I'll spend a little bit of time kind of dissecting the problem itself. So as I was mentioning earlier, when people get sick, they're not going to hospitals or the formal sector. They, for a variety of reasons, including what you mentioned and summarized, Neela, trust, dignity, comfort, and a lot of other factors. And because of that, the question obviously becomes that where do they go instead? And I want to delve a little bit further into that. So like I was saying, for a poor person, the family physician is essentially the neighborhood village doctor, neighbor, or uncle that's running a medicine shop. So whenever you get sick, you have a headache, you have a tummy ache, you have a persistent cough, you go to them, you run to them, you tell them your symptoms, and you pop whatever pill that they recommend, right? So if you look at the stats, it's actually quite staggering. In India, 47% of all out-of-pocket health expenditure happens at a pharmacy. So that's equal to every other healthcare provider combined in the private space. In Bangladesh, that number is 70%. So pharmacies account for more healthcare expenditures than more than twice the healthcare expenditures of all other health providers combined. And if I go by number of patient encounters, because pharmacies have such small transaction volumes, they would easily outnumber any other healthcare provider by 3 to 5x at the very least, although there's no data to back this up. So they are the trusted and the preferred point of care for most poor people and underserved populations. The problem is that they are highly decentralized and highly fragmented. So they're providing services informally without any support or oversight by the government. And as I was mentioning, governments in our countries tend to have this very Western notion that pharmacies are supposed to just dispense and nothing else. But that's simply not true in our countries. Here, people have a very different relationship with a pharmacy. And many pharmacists are also informal providers and vice versa. So what this leads to is that because the government and thereby donors and NGOs are not working with these providers, there are several gaps that ensue. There's capacity gaps, so they are not trained to deal with conditions that they encounter in a proper medically sound way. They lack the referral linkages. So if they encounter a particular patient and they don't have the wherewithal to serve them, they don't know where to actually send them. And thirdly, sometimes they even lack the products and services that are supposed to help that person get better. So this is the gap where Gion essentially steps in. Gion essentially introduces a combination of training, technology, supply chain, and formal sector linkages to upgrade a pharmacy into a better primary healthcare provider so that they can provide accurate advice and counseling, early screening, early treatment and referrals, along with the quality drugs and health products that would actually help address the problem. So if I were to go back to Navia's example with TB, if you're a poor person with a persistent cough and you go to the pharmacy because you have that cough, if that pharmacy actually was trained to identify symptoms of TB, and if they were linked to the government program or an NGO program that actually provides the DOTS treatment, or even in some cases in Bangladesh, for example, DOTS treatment is actually administered by pharmacies as well. So that was one of the few successful examples of engaging pharmacies in a public health program where over 30,000 pharmacies nationwide are actually providing DOTS treatment on a regular basis. And that would actually allow you to identify the cases earlier, treat them on site, therefore not requiring people to travel in order to access that treatment. And if a case is not getting better, then you know that pharmacy could actually also refer it upwards to the system so that they could get higher level care. So that's kind of one way that this all could come together, and this applies across many healthcare verticals. So that's essentially the problem and the type of solutions that we're working on.
Yeah, no, and I think what you said was so right. People use pharmacies in a particular way, right? Which is that they go every day and every time, and it's almost, that kind of repetition almost makes for a habit. It's my first response. If something happens, I'll go to the pharmacy. And also we know, like, psychologically, familiarity breeds liking. So, the fact that, as you said, so the volume of transaction means that, what does that mean? It means that people are going to their local pharmacist at least once, a few times a week. And they're seeing that person and they're seeing the pharmacist and they know the layout and they know what to ask for. And on the other hand, you make a very important point about imposing our idea of what this thing should do. So a pharmacist should be a dispenser, but that's not the way people are treating the pharmacist. So if we have to redesign healthcare, instead of saying, this is what a pharmacist should do, this is what families should do, stay out of healthcare, this is what, school should only provide education, it's better to actually meet people where they are and then say, okay, the gap is that there's no systematic, the gap is that parents can't make the appointment. The gap is that pharmacists are not trained. The gap is families are not trained. Why don't we fill that gap instead of trying to force people to adopt a particular model because it's convenient for us, and it
can I add one little bit, add some color to this? So in many cases, when you go and talk to poor people in rural or underserved areas, you'll find that people have a very long-standing relationship with one pharmacist, right, or one informal provider in that locality. Sometimes it's over generations. So your father actually went to that person's father, or your grandfather went to that person's grandfather. And although historically many of these were maybe the Kobiraj or other forms of informal providers, over the past 20, 30 years, many of these actually have become pharmacists. So they're actually now practicing allopathic medicine. And that's something that's often lost on many, even people in the public health space, that when we talk about informal providers, it's not so much that they are practicing some sort of quackery. They're actually practicing the same medicines or prescribing the same medicines that doctors are prescribing to us. So that's one point. The other point is that when you have that kind of an interaction with a person, the trust and the comfort that you feel, they're actually asking you not just about your own health, but about your grandmother's health. Like that's what the encounter is like. It's a very personal encounter. On the other hand, if you look at the government policy, in Bangladesh at least, I assume that it's probably similar in India. In Bangladesh, there was a law passed in 2010 that actually prohibited any non-physician, which means anyone with less than an MBBS degree, from practicing allopathic medicine. How much more disconnected can you get from the reality of people's lives? Like there's just no better way for me to explain this disconnect. But just yeah.
And this history patient's history, not just in terms of who you are, but your family history, I think is something which, and it really struck me when Navya said that the person who sort of said something might be wrong was not the doctor. It was someone who knew her well, a professor, who like noticed over a period of time and said this isn't normal to do that. So similarly, like it's only when you see someone over a period of time, you notice changes that they themselves might not notice. And so we shouldn't just discard that history with doing that. I think these are all, I think they're pointing the three models, they're innovative and different in terms of where they're meeting people, family, school, pharmacy. But I think I'm hearing similar threads, right? This thing about the recognition of the fact that, yes, there are these already existing systems of healthcare informal, whether it's the family, whether it's school, whether it's pharmacies, but there needs to be some training, some systematic training. So you can capture that rather than try and fight against that and change that. And again, this idea of, changing from a nuisance to an asset, right? How do you actually make that change? And that can actually lead to this is not just nice to have. So it can lead to reduced and to better outcomes, to better utilization of what you're going to spend on. And the third thing that really strikes me with all of these is that how much of this really makes the whole experience better, which makes people want to utilize healthcare. So, someone affirming my dignity, somebody that I trust, it's not necessarily just about convenience. I don't, decide to opt for healthcare just because of the convenience, but because of all these other factors. So I bet even if a neighborhood pharmacy opened up, many people would still go to sort of their pharmacy. I know my mother does that, that she would not go somewhere else not because of what is stocked in the pharmacy, but because of the pharmacist and the people who are there. And how she knows them. Again, it brings back this idea of people, whether it's the patient or whether it's the people providing. So I'm going to do a quick round, with all three of you in terms of what is the sort of top challenge you have faced in scaling your model? Just very quickly, if I know some of you referred to it, but would love your thought. What's the top challenge that you have faced in scaling your model? So let's start with Swati.
So surprisingly, we have had parents really embrace this model, and tier 2 and 3 city schools really embrace this because, they see the need for, constant health monitoring in their kids. And we've been signing 20-30 schools a month, which is great. But the biggest challenge would be to get the right partnerships established with the right schools who are willing to put in the effort, to let us get into the lives of the kids, educate them a little bit about, the different types of health, and also the hospitals on the other end, right, to be able to help us make this whole journey seamless for the whole family. So that would be our biggest challenge.
Can I just ask a clarifying question? Is that challenge that they don't understand, or they are sort of like, yes, we get it, this is really interesting, we'll do it tomorrow?
So no. Actually, the schools are getting it. It's the tier 1 schools that I'm finding a little bit more because they're so busy just focusing on education.
Yeah.
So we really want them to also look at it in a more holistic way. But tier 2 and 3 are way more willing to look at the health aspect. And although education is number one priority in most schools, but also we're really looking at scale in terms of at least reaching out to 1 million families, within the next 5 years. And for that, we will need both the school partnerships as well as really understanding hospital partnerships and the trust element that I was talking about. So we want good, reputable institutions working with us and not, we don't want to be just an aggregator of, say, every single clinic and hospital, but we want to be able to do right by our families and the kids.
Thank you. Rubai?
Thank you, Neela. Because we kind of started in this space very naively and not really knowing much about it, we were probably one of the early ones who started working with pharmacies from a public health lens as well. It's not been an easy journey for sure, and there's been many pivots along the way. And one of the things that I'll point out right at the get-go is that technology is the easy part, right? You can build technology for it. That's ever not ever the binding constraint, which we thought early on would be the main challenge. But what we've realized working in this space, and it's essentially a private healthcare space where these providers are very much driven by private sector incentives, right? So incentive is the key bottleneck to scaling or making many models successful. So for example, we ran a telemedicine model for a few years early on, but it just did not go well with their brand as a doctor, right? In the community, they're perceived as a physician. So if they're referring a patient to a telemedicine setting, what is that saying about their level of skill or kind of expertise, right? However, it's also not that just financial incentives is matters, because one example would be that during COVID, we actually launched an e-learning model for training these providers on COVID-19. And there was a certificate attached to it that came from the government, right? And that led to 25,000 people completing that course and doing very well with that certification. So we feel that every model that we've tried, incentives has been the main challenge to kind of figure out. The other thing is that convincing partners and governments to support you is quite hard in this space, because there's almost no evidence base. We're having to build the evidence base ourselves. There's pushback from the doctor community. So in fact, one thing that we've heard repeatedly, and one of my friends and mentors from India also told me that in India, doctors basically look at training informal providers as teaching thieves how to steal better, right? So we're swimming against the tide. And as I mentioned, there was a 2010 law that actually prohibited anyone but physicians from practicing allopathic medicine. So we're actually, like technically the things that we're doing, sometimes it can even be perceived as against the law. And that's something that is quite risky from a scaling perspective, because because no investor would want to put money into a model where there's no guarantee that the government would not come after us and shut us down several years down the line, right? And finally, I would say that making it profitable is extremely hard, because we're trying to serve poor people, and when you're asking or relying on them to pay a service fee, it's actually.
Oops. Okay, I think we lost them.
I think we lost.
I'll just give him like a couple of seconds to. Okay, it's a good reminder actually to people to we wait for him to get back, and maybe in the meantime, Dr. Noura. It's a good reminder to everyone on this webinar to please post your questions. I will start taking the questions. I have a few more, but I think it'd be good to hear from the audience about that. But while we wait for sort of Ruba to come back, and I think he outlined certain challenges, the lack of an evidence base to convince people, I think, and build that trust, regulation, thinking about regulation, because that sort of sets the stage for acceptance as well, and profitability, because a lot of these are social enterprise. I think that's an important question. So Shahid, just wanted to, what do you see as the big challenges with scaling up? And you've had a fair deal of success with scaling up, but what do you see as challenges with scaling up the Noura model?
Sure, I'll actually pass it over to Dr. Kaur to get her perspective, and then we'll fill in.
So Shahid would tell us better how he reached us and what were the challenges in reaching us. But after reaching us, the first thing that we learned was that we needed to reposition the care. And the most important thing was empowering the people in the healthcare system. Now, this is something that we were like, we've been running through a TOT the current days, and what we were analyzing that the Care Companion program is doing is putting all the services, integrating them horizontally and making it deliverable. Now, Government of India, and for that matter, many, many diseases, they fall vertically down from various levels, tertiary, secondary, primary, and whatever the basic level. And we all treat a human being as, the eye specialist will treat my eye, the nose one will look after my nose. And the programs also run like that. When I'm talking of tuberculosis, I'm not talking of my anemia, I'm not talking of my nutrition. So what we were able to do through this program is all the challenges that were all the programs that were coming down vertically, we were able to put them horizontally, integrate, and deliver them through the nursing sisters. So the first challenge was to make everybody understand the concept of time compounding and how we could get started with like the 2 minute concept. If everybody was getting 2 minutes, and if you put people together and 10 people together, so you have almost 20 minutes, and you could actually give the basic things to them. So we are now present in the antenatal, postnatal, neonatal, indoor medical, indoor surgical areas that covers the entire of the district hospital. So here is a nurse who comes in the ward, and she gives a session out there, and she's converted all our wards and hallways into classrooms. Now, initially, it was a very big challenge because it's a behavior change issue. And I know, don't need to explain, that's a very, very difficult task.
Mhm.
Yet, we were able to do it because uh, we all are ourselves very motivated. So, we are able to transfer our motivation further down. So, that's one another challenge. You need to have a very good team, and the team which is motivated, understand leaderships, understands, like when you talk of a very heavy CV, it really is heavy because it's got a lot of experience behind it, and that is a help, And
Yeah.
you got to also link up when you bring about a program which is to be implemented in the public health sector, right from the last mile, that's the end. Um, Service, the person who's going to get the service, to your health minister and the policy makers, and everybody need to understand understand and value that particular program. It was easy, but it was difficult. It was easy for everybody to understand that when I went to the hospital, I just got 2 minutes of the doctor. I did not even get 2 minutes. But then it is challenging to put everybody together and bring them to
Mm.
the point. So the best part here was that we had a solution about having an external faculty which was healthy and which is engaging, which is updated, and we've been able to overcome most of the challenges through that.
Got it. Shahid, anything to add to that? I mean, it is
I think
changing behavior.
less the challenges he faced while dealing with the government.
No, I'll zoom into, I think, one of the areas that you were talking about, which is doing anything in healthcare, definitely in public health, and trying to change something within the health system. You do have to take a multi-stakeholder approach, because it's not just the patients and their outcomes. Typically there's a frontline provider, and of course the administrators, bureaucrats that are in the picture too. And for us, I mean, I think at some level, the value to the patient is real in terms of the outcomes that we improved. But I think where we really when we think about it in terms of their need at the moment, it's not that they're trying to think about what are going to be my 30-day outcomes, or even longer than that, but it's really about what are the questions that I have now, what am I wondering, is someone going to be there for me that can actually understand and be there for me. So I think when we started to shift into that mode of really understanding their needs in the delivery of this program, and allowing the healthcare providers to meet those needs, I think was a hurdle that we were able to overcome. And then in terms of the providers themselves, of course, as Dr. Carr was mentioning, I think the behavior change at that level is incredibly difficult. When we started to, and of course this is a challenge still, but I think when we started to reframe this as not a program that's coming from even the state, of course not Nora Health as an external stakeholder, but not even the state, but it's something that we are offering as a way to help you support your workflow better, and problem solve with the providers on the ground on how they can own this initiative so that actually improves their their workflow and what makes it makes their lives easier essentially as providers was a really important frame shift. And then, of course, bureaucrats, administrators, they are tied to a specific amount of resources and a specific amount of quality that they're trying to reach in healthcare that's being delivered, and we need to play that balance in being able to share that this is a cost-effective initiative. And so, collecting the data on outcomes and costs um, and all that is difficult, to be honest, and being able to make that case. But so far, we're
Very
really
successful.
we're really happy to have partners like, of course, Dr. Kaur and the government of Punjab to be able to carry it forward.
Yeah, thank you. I mean, I think, first of all, I mean, props to all of you. Kudos for like really pushing this through as you're talking through challenges and thinking, my God, this is, it's nice to say this is my model, but it's hard work every single day to do that. And I took some notes in terms of, some of the sort of key challenges. Obviously, the first one is building those partnerships, right? At a certain point, it's not about one hospital, one pharmacist, one school. It's about you need to build partnerships, which takes time, it takes trust. And I also noted a couple of you talking about the lack of an evidence base. And maybe we need to think more deeply about, who funds that evidence base and who carries it out, because it's very different from the job of implementing. And unless we systematically think about that, it's not going to just happen. You're so busy implementing, then we need to think about the evidence base. And part of that is sort of building that trust, right? I mean, evidence is one part of the trust, but of course, relationships are more than just, evidence and data. And I was also very struck by, so it is about sort of motivational barriers in terms of, I like it, but I don't know if this will work. What's the evidence? It's about building trust. And also this idea of this intent to action gap. I like this, but I'm going to do it tomorrow, right? I'm not going to do it today. Like, it's not part, and incentives, what is my incentive to actually do it? And I think, Shahid, you sort of mentioned this idea, like if it comes externally, even if it's the best thing, I'm probably not going to be able to sort of adapt it. And yes, we all know that changing habits is really hard. And so you're not just trying to change habits of sort of patients here, you're trying to change habits of everyone in the system. I think one key point that was brought about is the role of regulation and government, right? So all this is dead in the water if, if there isn't regulation that carefully sort of obviously protects for risk, but also encourages this kind of innovation, because there is just this much you might be able to do in the private sector, but obviously regulation needs to be thought through. And finally, I think this notion of social enterprises, like what's the profitability? But I want to leave with sort of, I think what Rubaiyat said, technology is not the binding constraint. Right. So like, that's what we tend to think of. And that's the first thing, like, oh, we can solve it with technology, or technology is our biggest barrier. And actually this idea that technology is actually not the binding constraint in this situation. It's the trust, the incentive, it's all human behavior. And, so we need to think a little more sort of carefully about that. So thank you. I'll take, Bindu has asked a question, which I'll throw open to sort of, all of you in the audience, to the panelists, which is sort of this idea of listening to all of you, and I'll read out the question, makes me think that primary care must be embedded in many places, right? Rather than working for a pure play primary care model to emerge. So how can we do this more systematically? So, there is could we end up, so can we engage all pharmacists, for example, on a narrow condition like hypertension? Or, do you engage a pharmacist to do everything, and a school to do everything, and a family to do everything? So how do you actually sort of, is it worth narrowing? And what kind of investments do you think will help to realize this embedded primary care vision? So I'll throw it open to Rubaiyat, maybe you want to start.
Sure. No, I think we've actually approached it from the latter point that you mentioned about starting from trying to do everything. And then we realized that it's really hard to try to do everything at the same time. So we started narrowing it down. So initially, our telemedicine model was focused on general practice. So we were encountering patients from all kinds of symptoms and conditions. But over time, we realized that there's no referral infrastructure for many of those cases. There's no diagnostic facilities that could actually provide reliable diagnosis in many of those cases. And sometimes even the medicines, the supply chains are not good enough for the medicines to be available in those markets. So what we have now narrowed down to is we're starting off with a couple of areas. One of them is actually NCDs, and specifically diabetes and hypertension. Because the best part about diabetes and hypertension is that, well, the worst part is that it's actually growing really fast. So there's a huge market that's untapped and unserved. But on the right side, you don't really need sophisticated diagnostics for diabetes and hypertension. A glucometer and a BP machine is possibly all you need for routine monitoring and management. And essentially, a pharmacist with the right tools can actually do a fair bit in terms of doing the early screening, doing the routine monitoring and referrals. Even telemedicine is often good enough to have a consult with a doctor along with the blood glucose level or the BP level in order to provide a meaningful consultation, right? So if you could get to people early and if you could monitor them regularly because it's proximate, it's comfortable as an encounter, you could actually prevent a lot of the complications that come out of diabetes and hypertension in the long run, including MI, including, let's say, kidney failure. I've encountered patients who are 21 years old, had uncontrolled diabetes for a long time because they were probably type 1 diabetic and ended up with kidney failure, right? So you would be able to avoid cases of suffering and tragedy like that if you actually rolled out a very widespread model for NCD management at a pharmacy level. TB is another example. One of the reasons why handling TB has been so stubborn across many of our countries is that there's actually not a good infrastructure for primary level screening and referral, right? So if the pharmacist could be equipped with the right training and the tools to be able to identify cases early and then refer them, and maybe provide the routine treatment of Dodd's regimen, then you could actually see a tremendous change in shifting the direction of the curve. So I think those are some ideas. And I would very much argue that it should start in certain verticals, and possibly not everything will a pharmacy will never be able to do. But if you could at least create the right referral linkages, so a person that comes with some symptoms that, let's say, pain in your chest, that's not something that you want the pharmacy to handle, but you at least want the pharmacy to be able to tell the patient where to go in those cases. So that's those kind of referral linkages needs to be set up.
And I think it's a good point that the pharmacist can do some things well, and the equipment is there. It's relatively easy. It's low risk to do it. There are other things which might be more high risk that you actually want the pharmacist to maybe triage, but not actually do or make the recommendation. And then there are other things that, just not worth it for now till you get the system. Swati, similar question with schools, like where do you see the promise, in which areas the best that schools can do as opposed to the pharmacists or families or other places?
Sure. So when it comes to, the program, the big difference is everybody else gets to see patients in instances when they're sick or one point, right? So what is unique is that we have the beginning data set to begin with, right, about a specific individual, and we go deep down, and actually the concierge reaches out and gets the entire family to document their history. So what becomes important is that we're able to do follow-ups regularly, and this becomes almost like a one point where, I do realize that specialized, I think Rubaiyat was talking about picking one line, but here we're actually going the other way and saying we'll handle the entire, entire family and the entire range, because we have data, we have the ability to be able to triage the patient in the right manner. So, and I think what happens with the typical primary care models, and the reason we've seen a lot of these come in and out of the Indian ecosystem. And the reason they haven't been able to do well, one is, I think it's the ability to charge the patient. So, and the rentals, they just don't make sense at the end of the day. And second is, again, the trust factor, right? That comes in because a lot of these primary care centers depend on referral commissions. And that's a bad habit that needs to be broken. And that's the trust factor I was talking about that is lacking in the primary care system, that is pushing people away from actually, trusting these single centers. So, and going
No, and I think that's
constantly for
getting there. No, I think that's it. You raised another interesting point, which is that schools have this unique ability to longitudinally see, typically, like a lot of students, other than maybe a migrant population, etc., the same students, right? I mean, pharmacies do that many times. In this case, it's a cohort, and you can actually maintain those records. And so I would guess that things that have a lot of follow-ups or early preventions might be good places, because you're anyway coming there. This is something you would not go out of your way to do. You would not even think of doing it. It's just part of what you do. So that's an interesting, different take on, like, okay, here's a more focused model. Shahid, any thoughts on sort of where the Noura kind of model, do you see it more like the schools where you can follow the entire patient, so almost every or sets of patients, or more like very more targeted sort of approach with certain diseases or certain conditions?
Maybe somewhere in the middle. I think, no, I think Bindu's comment especially, we really resonate with that, because primary care is at some level about equipping people on their health journey. It's not just about clinics and doctors, of course, all the time. And of course, we all believe that. And I think one place where we're seeing this interplay is our WhatsApp program that we've started, which allows people to be supported on their health condition at home through WhatsApp, essentially, right? And what we're hoping to do is to create, a more longitudinal relationship with them, and essentially be their go-to health resource whenever they have any questions, not just about, let's say, if they just got trained on how to care for their baby after being discharged from an NICU, not just for that, but when the baby grows up, and there might be other issues as well. So that's definitely, top of mind for us as well. And I suppose that approach is similar to this kind of beginning narrow, and then, hopefully building out something a little bit more systematically. So
Yeah.
I think so. Dr. Kaur,
But I think, yeah. Any thoughts, Dr. Kaur?
Yeah, I think she's come out with a very good model, and I mean, they must have a lot of data to back up what they're doing. I do not know if you're familiar with the RBSK program and its deliverables, and government has a very good initiative. About the public health system, I was listening to all the speakers, and I saw that there is a lot of things being done, even about the pharmacies. The National Tuberculosis Control Program is getting data from the pharmacies and following up with all the clients there too. And we've been doing it in Punjab also. And school health programs have been there. And I, as a very young doctor, have been going to the schools and looking after the health of the children. Of course, we didn't have that kind of digitalization during those days. But today also we could take forward. I mean, there are the RBSK linkages can be going forward onto this direction too.
And I think you raise a very important point, sorry to interrupt, which is that we have these models, they exist. Maybe we are looking at a version 2.0, right? And this is what we could learn from sort of some of these innovative models where there is, and, I know that a lot of the panelists spoke about the need for partnerships. So, and meeting people where they are, it's not just meeting patients where they are, but also meeting the government and meeting doctors where they are. And one way to do that is if you frame it as saying you're already doing this in some way, right? There is already a program to do this. What you need to do is to maybe look at adapting that program. But that's the perfect, thank you for that. That's the perfect sort of a segue to the question that Nachiket raises, which is, given the need to be flexible, adaptable, and highly responsive to patient needs in primary care settings, is government the right owner, manager? Should governments be prepared to partner with specialized providers. And I'll start with with Noora, because we do have Dr. Kaur here. And you spoke a little bit about the role of government in managing some of these programs. But do you have thoughts on, I know a lot of this might be, it depends, but just thoughts on what the government role ideally should be. Because if you're going to get healthcare to 1.3 billion Indians, it's not going to just happen with, however innovative our models are, right? Ultimately, you do need to partner very closely with government.
Yeah, I mean, I'll answer from maybe more narrowly our case, and then Dr. Kaur, you should would love to hear your take on this too. But for us, I think um, we we feel like the balance is struck where we're coming in as a technical and capacity building partner and improving. There's interactions happening with the government health system every day between patients and providers. There's facilities that exist. There's HR within those facilities, and a lot of care that's being delivered. And the specific approach that we have is about adapting that care so that we involve another asset, as Dr. Kaur was mentioning, in the family, and then build a more resilient community or more resilient care delivery network at home through people and their patients and their families themselves. So I think in our particular case, because the government is already doing this, they are implementing care delivery at multiple levels of care, and this approach is meant to kind of strengthen that. I do believe that they have that implementation and kind of ownership of delivery of the model as well, and we're there more as a capacity builder. But I do think it's case by case in terms of um, exact model, and if that's an innovation that is bringing in something new that doesn't already exist within the system. So, Dr.
Yeah.
Kaur.
Yeah, see, I do not know how much you've educated on all the national programs, but government has many, many programs.
Yeah.
And all the programs, when we build the programs, when we document them, and when we want to train people on them, lot of effort and lot of, intelligent resources put together to. But while we are implementing, we have local challenges.
Mm.
We have provisions of modifying the things where the government could be sometimes slow in one area, and there could be somebody who could partner in and give good better ideas. Like we got Shahid coming up with this beautiful idea, and I get it from both of you, Swati and Rubayat, that we could have some merger somewhere, and where people come in and um, uh, bottom line is
Yeah.
government has the best structure. And today also, if you have to reach the last mile, that's the last person, that's if you have to reach my house, it's much easier to reach through the health and wellness center, through my ANM and my ASHA, provided she reaches my house.
Yes.
What I need to ensure, and that's what we need to work on. That we have all the health and wellness centers in position, and in India, I'm not familiar about Bangladesh. We have now added a mid-level healthcare provider, so doctor is not the first contact. It's the
Mm.
community health officer who's the first
Yeah.
contact, and that community health officer is placed for every 5,000 population and closely inside the population, which is rural as well as the urban setup. But we need to empower them, strengthen them, and make them capable of delivering all that. Swati, Rubaya, Shahid are coming up with various models. So happy
Yeah.
to join everybody.
But I think you raise a good point, which is that it's, if you think about it, there is various innovations and say, take any category, shampoo category. It's not that people haven't been washing their hair. They have been for hundreds of years, but you keep finding better and better and better ways to do that, right? And so similarly, I think rather than think about, is this a new thing? Is this existing? It doesn't matter in some sense. The important thing is to say, what's the version, what's the version 3.0, 4.0, 5.0, and how do we embed that? We just have a minute, so I will have, and then I'll wrap up. I know there are a lot of other questions as well, but we're out of time. But Swati, Rubaiyat, any thoughts? Rubaiyat, I know you spoke about the role of government, particularly in terms of regulation, but how have you thought about sort of government in this scenario and with respect to Geon?
Yeah, so our case, as I mentioned, is a little unique because we fall in the legal gray zone. But at the same time, I think it's important for governments to also be responsive to people. And so if 70% of people are still going to the informal sector for care, rather than ignoring their existence or discrediting them in policy, it's important to bring them under some sort of a regulatory framework that actually allows them to become better and provide better services, right? So what we've been advocating with the Bangladesh government is essentially that these pharmacies or other informal providers are brought under some sort of an accreditation framework, and that they can partner with an organization like Geon or others who are working in this space to build their capacity, introduce new technologies to them. And it's completely fine for the government to actually ask for the right evidence, right? So if the Ministry of Health asks us for a research project that actually shows the outcomes and demonstrates that our model is actually helping people or having the desired impact, we're more than happy to do that. It's just that conversation and dialogue needs to be always open. I think the government, rather than restricting innovation, I think the government's role should be in modulating and regulating innovation in a way that actually benefits people.
Yeah, that's great. Swati, any final?
Yeah, Neela. So the government has actually done a fairly good job of mandating, most of the schools and a really good structure around it. It isn't compulsory, but at least, it's out there. All the curriculums or all the boards have actually embraced this as well. So I hope they, get schools to implement them. And I think the government has woken up to school health as a big element.
Yeah.
So it is a good thing, and I think they should be involved.
Great. Well, thank you. Thanks, everyone. I wish we could have continued. At the beginning when we started, I said, oh, my goodness, 90 minutes. I'm not going to have enough to say, but I wish, I feel like we can continue this for some more time. I just took a few takeaways. Yes, it is possible to meet people where we are. There was a question about, what are other models? I don't think this is the last on this topic, and these three are the only ones. There's employment-based, meeting people where they are. That's another part of people's lives. There might even be entertainment, movie theaters. Why don't we think of all these places as healthcare opportunities, right? I think thinking through carefully what that place is, what it does well, whether and what it can and cannot do is kind of important. And you've certainly thought very carefully about your model, and definitely challenges in scaling this, building trust, motivation, incentives, but also regulatory challenges, thinking through what the role of the government is in sort of scaling this up to universal healthcare. And I just want to come back to sort of this idea that at the end of the day, people choose healthcare not only because of price and convenience, but also because of the experience of trust and dignity. And I think we ought to think a little more carefully about that. So thank you so much. And, we'll be back with another series, maybe looking at other venues, maybe going more deeply into these models. Follow us. And if you want to contribute to the Lancet Citizens Commission, please get in touch with us. And it really is this perspective from all citizens. So thank you, Shahid, Dr. Kaur, Swati, Rubaiyat, you've been awesome. And Navya, of course, for sort of setting the stage. Thank you. And thanks to Noura for helping us.
Thank you so much.
Thank you.
Thanks, everyone.
Thank you.
Thank you.